See, many of these women present to us in the either in the adolescent stage or in the reproductive. As a consultant gynecologist and obstetrician, we meet these women around this period of life. But I feel it very appropriate at the time of diagnosis. When you have made the diagnosis of polycystic ovarian syndrome, it is very appropriate to talk to them about the metabolic risk, regardless of their age or their weight or anything like. So we all know that PCOS is not just confined to the reproductive system. So we have to tell them about the metabolic risk, so that it even gives them like a boost or a morale to work further on this like disease.
Thank you, ma'am.
So we also screen them for blood pressure, lipid profile, the waist hip ratio. We check the blood pressure, the glucose, the cholesterol also in those women at that time. So we can focus, we can have a focus discussion on these women about this metabolic risk. And
Yeah.
regarding your second question, when to refer to an endocrinologist? So many of the times they come to us with like irregularities in periods or just fertility management. Or the mothers bring their young girls to us with the very irregular pattern of adolescent PCOS. Sometimes, very rarely, we see the extreme varieties where they don't have periods and they have insulin resistance, and some women with like lipid profile abnormalities also, they also come to us at times. So my trigger to refer to an endocrinologist will be like the resistant variety of PCOS, where we find it difficult to manage them even with menstrual irregularities or fertility when they are not able to conceive, the resistant varieties. So I would refer them to an endocrinologist. And of course, when we see the metabolic pattern, we are not the people to treat them especially, so we would like to refer them to an endocrinologist. And also, when I have an unclear diagnosis, sometimes we feel that they are having symptoms or the what you say the PCOD, but the diagnosis doesn't prove, that is the biochemical pattern or the ultrasound also doesn't show the PCOD, but we somehow know that the symptoms do match with the PCOD, but the diagnosis is also unclear. Sometimes so much things overlap with them, the hypothyroidism, sometimes they will be a borderline diabetic. In all those instances, we would like to refer to an endocrinologist.
Thank you. So just to summarize what ma'am said, that yeah, the screening for metabolic risk needs to begin right at the beginning of diagnosis of PCOS. We don't know when it's the correct time to discuss, but probably, yeah, at least measuring a blood pressure and checking basic parameters like blood sugar and lipid profile right at the diagnosis of PCOS also will help us in diagnosing metabolic risk. Endocrinologist may be involved at an earlier age, especially I think with adolescents or with people who are having resistant type of PCOS where the primary concern is not being treated properly, or when we are suspecting the alternative diagnosis to PCOS which present with hyperandrogenism and anovulation, for example, hyperprolactinemia, hypothyroidism, late onset congenital adrenal etc. So we'll go to Dr. Chitra. I think when I was introducing her, I swallowed the words MS Ramaya Medical College. So she's an associate professor of endocrinology in MS Ramaya Medical College. So we'd like to ask her, what are the clinical parameters as far as history and examination are concerned that you would like to check to assess for the metabolic risk factors?
Thank you, Dr. Santosh. As I am learning to find my footing in this world, I have also learned that I must correct things which are wrong. I am professor and head of endocrinology in Ramaya Medical College. So I'm going to say that. Okay. And quickly coming back to the question in hand, what are the clinical parameters and when should we look at metabolic risk factors? I think it's important for us to kind of remind ourselves and recalibrate our understanding of PCOS itself. While it is a condition which usually presents with dermatological or reproductive manifestations, it is at the heart of it a metabolic condition. At the heart of it, there's insulin resistance, which is the soil, which kind of has various manifestations through the life course. So while they might reach out to us with irregular periods or let us say acne or hirsutism, it is important for us to understand that the insulin resistance does increase their risk of having gestational diabetes, type 2 diabetes, hypertension, dyslipidemia. There is a lot of evidence to suggest that women with PCOS have a greater and earlier onset of cardiovascular disease. Not to forget other conditions like sleep apnea, which is reported to be common in women with PCOS, and not to forget the huge load of mental health. We have an entire session dedicated to that. So it's important for us to recalibrate this and kind of present it like that to young women reaching out to help with us, to say that at baseline, as we've noted with Dr. Bindu, and at every single visit, that you screen yourself for metabolic parameters. And it's also important to understand the burden of metabolic history in their family. I strongly recommend that we should take a detailed history of metabolic risk factors. How many parents, grandparents do you have with diabetes, hypertension, heart disease, or stroke? And this is important because whatever runs in the family, you're more likely to have it. So that will give you some clue. And that's also a good time for them to reflect on and kind of understand their metabolic load. While we might all know, I think we clearly don't understand the connection between our family's risk factor and our own risk factors. Many bulbs go off when we take that history. That's important for us to understand. And I think with examination per se, we should definitely look for weight, height, and BMI. Definitely waist circumference. A waist circumference which is greater than 80 centimeters in women is considered to be central obesity, which increases our odds of having metabolic complications quite significantly. Of course, if you are being thorough and if you have a lot of assistants in your clinic, you could also check a neck circumference. There is some evidence to suggest that neck circumference greater than 32 centimeters in Indian women increases risk of sleep apnea and metabolic syndrome. There's a lot of accumulating evidence about this, but waist circumference would be minimal. And what metabolic parameters would you screen for? I think we'll come to that question in some time, but I'll hand back over to Dr. Santosh.
Thank you for correcting me. I'm sorry for not updating myself. So, and yes, so Dr. Chitra clearly mentioned about what are the things that you would like to do at a baseline clinical examination. And she so well talked about both the parameters that are as far as family history is concerned and personal history is concerned. And also we spoke about the various examination factors, which could include a basic checkup of the blood pressure, the weight, the body mass index, the waist ratio, and if possible, even the neck ratio, which helps in preventing the future metabolic, predicting the future metabolic risk. So we'll go to Dr. Sweekruti next. So what are the lab parameters that are essential in determining the metabolic risk?
Very good evening to everyone. Thank you, sir, for that question. I think we have discussed a few of the lab parameters as well with the previous panelists, but three in PCOS, irrespective of BMI, all the patients should be screened for certain metabolic diseases. And the important things that we need to remember here is the glycemic status screening, lipid parameters, and LFT. Most commonly, these are the important points to see. When we are talking about the glycemic parameters, it is always, if it's possible, an OGTT is always preferable, the 75 gram of glucose load with the fasting plasma glucose and a 2-hour post-glucose plasma glucose. HbA1c, if you consider the fasting plasma glucose, is better as compared to the HbA1c. And in some patients earlier, we used to do a fasting insulin to see a HOMA-IR, though we don't do it as much as often as we used to earlier, but it can be used to somehow see the risk of insulin resistance in some patients during early screening of metabolic risk, and maybe warn the patient for a better lifestyle initially. However, due to assay variabilities and many other factors, we do not do it that much in considering the endocrine society guidelines. And in the lipid parameters, obviously a fasting lipid profile and LFT, just because, as ma'am said, Chitra ma'am, that insulin resistance is the common soil for a lot of other metabolic diseases, and MASLD is one of them, and which is a definite risk also in PCOS patients. So a screening at the screening point, liver function test can be done. So these are some of the lab parameters that can help in determining the metabolic risk.
So Dr. Sweekruti has so nicely told about the various lab parameters that need to be checked at the basal visit and also in the follow-up visits. So we'll go to Dr. Bindu. How often do you see patients who are having classic PCOS on ultrasound, but they don't have any signs of metabolic dysfunction?
Yeah, see, many of the times we see this polycystic ovarian morphology in ultrasound, especially in the adolescent girls when they come to us. Sometimes, like they might have done sonography for some other reason, or even that around that reproductive age group, early reproductive, that is at early 20s, or sometimes these women come to us with a health checkup report showing this polycystic ovarian morphology on ultrasound. That is, they have this, they don't have any other, they have regular cycles, they don't show any metabolic dysfunction. So it might be not very often. We, yes, we do see, if I see 4 or 5 women with PCOD, one may be having this, around 20 percentage you can say. But most of the times this may be like, we will have to counsel them that follow up is required, and you definitely have to like think about the lifestyle management changes, and just watch your cycles and your like what, how they are doing. And this may be, they may, this may be, we just counsel them and say this may be a normal variant also, or it may be a pre-PCOS factor. So definitely we will have to keep a check on these women, and we'll ask them for follow up, definitely.
So Dr. Bindu has very clearly told that, just a classic PCOS on ultrasound with no other features of like irregular periods or hyperandrogenic signs, they also can fall under a spectrum of what we call as the PCOS basically. So PCOS comes with a variety and a large spectrum of presentations. One of them is this, and these patients also should not be ignored as far as checking and following of a metabolic dysfunction. So we'll go back to Dr. Chitra. Given that many PCOS patients have a normal HbA1c level but high fasting insulin, should we be slowly moving towards the HOMA-AR as a standard diagnostic tools? Can you explain to the audience more about the HOMA-AR test and what is its significance?
This is a great question. Thank you for asking this, Dr. Santosh. So we do screen with good intentions and we find HbA1c, which is normal. Does this mean there is no metabolic risk? Does that mean while we are all concerned about insulin resistance, it's not happening? The HOMA-IR, while it is a good tool for us to assess insulin resistance, has a lot of technical difficulties in terms of accurately being validated as a mode of saying that you are insulin resistant or not. That has been a challenge. There are many challenges, some technical related to lab methodology, and some others related to the fact that we are just very heterogeneous groups. And if you are from a family which has a very low beta cell reserve, you might have a large insulin resistance, but your HOMA-IR reading might actually be falsely low. So there are many challenges. So if that is the challenge, then how can we assess whether you're at risk for metabolic syndrome or insulin resistance? One good tool is to do the waist circumference. A waist circumference greater than 80 centimeters is simple, non-invasive, and very good to answer your question. But if you want a little bit more evidence, which is sometimes which we do need to motivate individuals to kind of get them to pay attention to their health, would be a fasting lipid profile. And you can, in some way, infer from the lipid profile if you have insulin resistance or not. So, if you have a low HDL value, a high triglyceride value, you have insulin resistance. And there are very few people who have a normal lipid profile in the Indian population. We have the recently published ICMR, a large study which was published about a year ago in Lancet. Close to 88% of people had an abnormal lipid profile. So that might be a good tool that we can use. And also that's a good tool for us to kind of track to see whether they're making lifestyle changes, because if you're incorporating movement regularly, your HDL should improve. If you're paying attention to your food choices and eating healthier, your triglycerides should move down as well. So that might be a good tool which we need to track as well. Instead of doing HOMA-IR, where the fasting insulin can range from actually 6 to 35, and there's really no way that we can call that as normal, call that as abnormal, or even track that for monitoring purposes. I hope this answers your question.
Yes, I think it answers it very clearly that HOMA-IR may be a objective measurement for monitoring insulin resistance, but given that we are an extremely heterogeneous population in India, we don't even have normative data as to what the fasting insulin should be, leave alone calculating a ratio like HOMA-IR. I think the better way would be to check for clinical parameters, especially the waist circumference and the lipid profile, which he says the improvement in the triglycerides and the increase in the HDL with whatever treatment that you have given to the patient for helping in the metabolic syndrome parameters. I think that will serve as a better tool rather than the HOMA-IR.
Can I just come in, Dr. Santosh, with just one more point? But in women with PCOS, actually, the strongest evidence for glycemia assessment happens to be the 2 hour post glucose value. Uh, there are large number of studies which are done internationally and also in India to suggest that the first abnormal blood glucose is your 2 hour post glucose blood glucose. So if you really want to show that your blood sugar levels are off, that might be the test to do even in situations where you have a normal HbA1c. Over to you, Dr. Santosh.
Dr. Swikriti, which percentage of patients in PCOS actually have a problem that is contributed by adrenal glands rather than the ovaries? And does the treatment approach metformin versus lifestyle changes for the androgen excess, if is primary adrenal based, will it change?
Sir, earlier some studies have mentioned that up to 20 to 30, in somewhere 40% of the hyperandrogenism is adrenal derived. However, even recent studies have shown that almost 50% of women with PCOS, the androgens are derived from the adrenals. So as we all discussed, the common soil for PCOS is hyperandrogenism, insulin resistance. So whether the androgens are adrenal derived or ovary derived, we have to attack the insulin resistance. So the treatment approach does not change as such. However, especially because we know PCOS is a diagnosis of exclusion. When we do a screening of PCOS at the first hand, when the patient has presented to us, we do hormonal parameters where we do see the DHEAs, and if the values are such that they are suggesting something beyond PCOS, that the treatment approach completely changes. Whether it's if we are suspecting other causes like NCCAH or other adrenal causes or adrenal tumors, if DH is too high, that the treatment protocol will change. However, if it's just a PCOS and it's adrenal derived androgens are at a higher level, the treatment approach still remains the same with lifestyle intervention and metformin. Both can be given, and the treatment approach is the same basically.
Right. So we now go to Dr. Bindu. We'll ask, does weight loss advice still hold good value for a person who is having a BMI of 21? Do we think we should talk about diet and exercise to this sort of people also, or are we causing more harm than good?
No, not at all. We are not causing more harm. So actually, the when you talk to obese women or the lean women, the focus should be on weight loss, especially in obese women. But for lean women, we should say the weight maintenance is important in them. And when you probe deeply into them, we find that they have so much of diet issues. Their diet is not good. They have sleep issues, they have stress issues, so many, so they have basically a bad lifestyle. So it is very important, the emphasis should be on a weight maintenance, and you should also tell them like you will have to manage your lifestyle in such a way. Lifestyle management is especially important with a good diet and also exercise. So it definitely, the way ahead is lifestyle management only.
Right, ma'am. So in the same breath, can Dr. Chitra help us in understanding about the lean PCOS? They don't look like they have insulin resistance. How do you even speak to these sort of patients to talk about lifestyle when they say that we are already so thin? What else can we do to be more fitter than what we are?
Yeah, so this is an important challenge, but I think with the rising prevalence of obesity per se, we are seeing lesser and lesser individuals who are lean PCOS per se. But there is evidence which has been documented to suggest that even though they might be lean, by our estimates, they are insulin resistant per se. And almost all women who are lean by BMI alone will have a waist circumference which is crossing 80 centimeters. So I'm going to come back to harp on that. Definitely for sure. And does this mean they are at lesser metabolic risk? That is the question. But apparently there is no protection towards metabolic syndrome in these women as well. The rates of progression of women who are lean versus not lean when it comes to onset of any of the metabolic parameters or GDM for that matter remain high as well, which would get us to mean that we will probably be needing to screen them for metabolic parameters at the same frequency as women who are obese per se.
So Dr. Uday would like to say something at this juncture. Dr. Uday, please.
When we talk about US, can you hear me?
Yeah.
Hello.
Yes, sir. Yes, sir.
Yes, sir.
So what I would like to say is for lean PCOS, it's important to make them realize that it is not weight loss, but it is musculoskeletal exercise, which ultimately will help them to bring down the insulin resistance, because insulin resistance is the pathology even with them. So it's not so much about weight loss, but they need active metabolic musculoskeletal exercise needs to be done by them, so that ultimately the insulin resistance decrease, because lean PCOS are more difficult even when you are dealing with infertile patients and stuff like that. So it is important to counsel them that it is not weight loss, but it is about doing a musculoskeletal exercise, which will ultimately help them to bring down the insulin resistance.
Right.
Hello.
Yes, sir. Yes, sir. Right. So we'll move on to Dr. Swikruti now, because we are now in the last 7 or 8 minutes of our program. So let's ask the most controversial question here. Now, people will come and talk to you about all fad diets like intermittent fasting, keto diets, high protein diets, and then they'll say, this type of exercise is better than that. Could you throw some scientific evidence, or could you like to summarize all this in good scientific way so that everybody can understand?
So when we keep talking about lifestyle, exercise, diet, but as you said, there's no sign. I mean, they don't say it in a proper way that this is what we need to do. So if we talk about guidelines about exercise in PCOS, it's 150 minutes of at least moderate intensity exercise per week, and or 75 minutes of vigorous exercise plus 2 days of resistance training. So, as Sir was saying, that even in lean PCOS, exercise is important, not just to lose weight or inch loss, it's more for the insulin resistance, which is at the skeletal muscle level. So, if you talk about numbers, it's at least 150 minutes of moderate exercise per week with at least 2 days of resistance training. When we talk about diet, it's all the basic things like avoiding junk food, ultra processed food, and high fiber diet, and low GI carbohydrates. All that I think most of the PCOS patients also know, and they research a lot about it. Fat diets, if we talk about fat diets, is if we talk about some of the common fat diets, keto diet, yes, it's not that easy to sustain it with a high protein, very very low carb diet, and it does have other issues like constipation, or less fiber in the diet, and renal stones, increase in LDL. Some of these things are there, some concerns are there associated with keto diet. Intermittent fasting, if patients can do it, follow it, it's good enough for calorie burn as well as some degree of improvement in insulin resistance, but it needs to be sustainable and it needs to be properly done, because sometimes PCOS patients have stress eating and they do this binge eating cycles. When in their fasting window they'll be fasting, and in the eating window it will be a complete junk food during that period. So that is also something that needs to be kept in mind when you're doing an intermittent fasting. And detox diets, juice diets, I think all of us know these are just fads and they are not sustainable. 2 week juice diet or water diets, some sort of diets, PCOS patients are desperate when they want to lose weight. So for them, mostly what is important, it needs to be a sustainable pattern of diet, and especially all the good things, good fibers and low GI food, all of that. And intermittent fasting, I feel, is good enough if you don't do that binge restrict cycle and you have a healthy eating window. And one more thing that PCOS patients come and ask me is about nut cycling, seed cycling. So seed cycling is usually in the follicular phase, they take flax seeds, pumpkin seeds, and in the luteal phase they're taking sesame seeds or sunflower seeds. There's not much evidence regarding that, but it's some research shows that it helps in the ovulation, or some zinc, lignin, some factors are there. Though we do not advise it to our patients, but some patients think maybe it's a placebo effect. They do feel that it has an effect on the cycle. So that's also another fad pattern that they follow.
Right. I think the key word over here that you've used very nicely is sustainability. So whatever you do, if you're not able to sustain over a period of time, it's not so good for you after all. It will give you short-term results, but not long-term results. And PCOS is not a small 100 meters run; it's a marathon. So, Dr. Bindu, we know that insulin resistance does affect the quality of the oocytes. At what point do you stop treating the infertility and first insist that the patient stabilizes their insulin levels before they consider, going to treatments like letrozole, clomiphene, or other factors like IUI, IVF, etc.?
So we are all aware that insulin resistance is affecting the follicular environment, the egg quality, the and more incidence of miscarriages and more chances of gestational diabetes all come with insulin resistance. So definitely we have to stabilize the insulin levels. Along with this all, it's not like you should first stabilize the insulin levels, then you should start ovulation injection, then you should say about the lifestyle management. It all goes together. It all goes to in a toto. So like along with lifestyle management and before we start fertility treatment, we have to stabilize the insulin level. So and we see some women come to us with PCOS and spontaneous conception also, but we see more of miscarriages in those women also. So definitely, if a woman comes to you for fertility management, if we see insulin resistance, I would like to stabilize the insulin levels also simultaneously.
So I think the key take-home message is managing the metabolic factors in PCOS has to be done at every level of management of PCOS. Let it be a child or let the prepubertal level only where you have certain signs of PCOS in the future, or let it be even a person who is more than 45 years old. So lifestyle has to come at every step when you're managing the concerns of person with PCOS. So Dr. Chitra, now the $1 million question
Dr.
is
Santosh, if we could interrupt very shortly, we need to stick to time.
last, I think. Okay, just one. Let's have a just a minute session now for Dr. Chitra, GLP-1 receptor agonists and PCOS. Just a minute.
GLP-1 is not approved just for use in PCOS per se, but if you have your person who's sitting in front of you with a BMI greater than 30 kg per meter square or a BMI greater than 27 kg per meter square with diabetes, hypertension, or sleep apnea, which is more common in women with PCOS, you can very well use the GLP-1 or the dual agents which are available, although it's not approved for use just for PCOS as of now.
Thank you. Just a minute, Dr. Sweekriti. Metformin versus myoinositol to address the various concerns of PCOS at various ages. Which agent is better for what concern? What are the evidences?
If we talk about evidence, then myoinositol does not have that degree of evidence to be used in PCOS. If we are talking about metformin, when the metabolic risk is there, obese patient, insulin resistance, MASLD, metformin is definitely the first line drug. In patients who are maybe metformin intolerant or lean PCOS, maybe we can try myoinositol, but there's not much evidence to support this.
Right. And so all the panelists in 10 to 15 seconds, if you could change one thing about how PCOS is managed in common practice, what would it be to ensure better outcomes for women in their 40s and 50s? Dr. Bindu first.
Yeah, single most important first early early implementation of lifestyle changes, and it should be consistent.
Nice, nice. Dr. Chitra.
Don't blame and shame the young woman or the adolescent who's coming in. Give them the tools to make sure that they can understand their own body, health, nutrition, and self care better.
Dr. Sweekriti.
I would just second that lifestyle is the first thing that we should change in a PCOS patient.
Good. So I hope Dr. Tejal is happy that we wrapped it up so fast now. So it was a great discussion, to be very frank, and we got to hear multiple things from many people, right from when to screen for metabolic, how to screen for metabolic risk factors, and how to manage them. With that, I rest my case, and we hand over back to Dr. Tejal now.
Thank you.
So thank you so much. And we will just quickly go on to the next panel discussion. And please note that, okay, never mind, we're among friends. I was scolded that I was not keeping to time. So I'm going to quickly share my slides and I invite my panelists to please be available I hope my slides are visible.
They are, but you'll have to make it the full.
Yes, yes.
Yeah.
Is that okay?
Yes.
So good evening, everyone, and we are at 8:45. So should I aim to close by about 9:15?
Yes, please. Thank you.
Yes, because Dr. Thanawala is waiting. Okay, so thank you, everyone. Just at the outset, I just sent one message to Dr. Parulekar, and then everything just fell into place. Dr. Bindu, Dr. Thanawala, Dr. Suchita, everybody just came on board and said that they would, be happy to coordinate with us. And my panelists today are Dr. Anis Joseph, who is an endocrinologist, Dr. Shweta Chavak, who is a psychologist at IIT Bombay, and Dr. Bharti More, whom we all know is our gynecologist from Navi Mumbai. And I will be moderating the session. So I'm going to dive straight in. And my first question is for Dr. Shweta, that what is the impact of any chronic condition on the mental well-being of a person living with the condition? The reason I've kept the question open is because Dr. Shweta not only has a lot of experience in chronic conditions like diabetes and PCOS, but has also done some excellent work on the subject of cancer and people living with cancer as well. Dr. Shweta.
Thank you so much, Dr. Tejal, for the introduction. Just a correction there. I'm a researcher and a psychologist, but also I teach at IIT Bombay. So just starting with the conversation, I think what we have been going through till now is to understand that when it comes to mental health well-being of an individual, it is not the diagnosis itself, but it is about the journey that they have. As in the previous panel also, we had this discussion on talking about lifestyle, diet. So I think this is something I always tell to a lot of physicians I work with is that the diagnosis you are giving is you might have heard it multiple times, but it is the first time they are listening. So it's a lot to process. There's a lot of information to process, as we discussed about diet, lifestyle change, as Dr. Bindu and we all were discussing about how these people are already struggling with their lifestyle and they are desperate to lose weight. So adding this and adding along with that the added idea of how society looks at these conditions all have an influence on or leads to individuals feeling mental health or impacting their mental health and well-being, and that leads to higher distress level. So it's not just about looking at the diagnosis, but it's the information they receive, the society, and how they perceive their own diagnosis. Do they feel they have control, and what is the stigma associated with it? Just to give you an example, PCOS is always seen as a infertility issue, right? So something on those lines is what we see, and that has an impact on individuals' well-being. Yes.
Thank you so much. And so how does this translate? Sometimes we find patients seem very what is the word? They seem very close during a consultation. Sometimes they're very anxious. So I think different people express how they feel in the consultation differently. So could you shed a little bit of light on how the patient's body language is and what it actually can mean?
Yeah, for sure. Everyone's response to a diagnosis would be varied. So starting with looking at like how do they, so what we talk about is the perception of illness. How do people perceive their illness? Do they see threat towards the illness or do they accept this as it is? And so depending on the condition, we have a lot of experience. So for example, in cancer, if they know about the illness and if the way society looks at cancers, cancer means equals to death, that can have an impact on people to feel more fatalistic towards it. But on the other hand, when we talk about diabetes we call it as sugar. So aapko sugar hai. So when you say, like when you talk to a patient and they say, "Ha, but mujhe to sugar hai. I stopped having all the sugar." Then why is my diabetes not normal? So you see, the way they understand the illness is very much important. How do they perceive it? How do they comprehend it? And also the society. How do they look at the condition? Are they pitying them? Are they stigmatizing them? All of that contributes to how they would respond to, and also what kind of health issues, mental health, well-being issues they'll experience.
And also what baseline mental health they're coming in with, probably.
For sure, for sure. But again, it is not limited to, it's not always that a person who is already experiencing distress will have a distress response. It could be also a very much healthy individual experiencing distress as well. So it's more of like a continuum that we look at. So well-being is seen as in a continuum itself. So it's based on the situation, how do they respond to it, and what kind of distress level do they experience.
Thank you so much, Dr. Shweta. So my next question is for Dr. Bharti More. And what aspects, reproductive aspects of PCOS, do you think, Dr. Bharti, are the ones which impact the mental health of women with PCOS? Is ma'am here? Ma'am, you're on mute. Can you please just unmute yourself? Yeah. Yes, you are.
Yeah. Tejal, thanks for the question, and I thank Emojis for allowing me to participate in this panel. First of all, now PCOS has become like, a everyday word. The patient comes in the consulting and she first says, Doctor, mujhe PCOS hai. So it's become like channa vatana futana, and the patient comes and tells us it is PCOS. Especially when there's a girl who is not even 12 years old or 11 years old, she has menorrhagia, irregular menses, but her mother will say, no, aisa lagta hai ki mujhe PCOS hai. So that itself is mentally distressing to that girl. Talking about the reproductive aspects, because the
Dr. Anis, are you able to hear Dr. Bharti?
No, ma'am. No, ma'am. No, not audible.
Dr. Bharti, your net is a little bit slow, I think.
Because of the Am I audible here? Hello?
Yes,
Yeah,
ma'am,
but
you are.
switch off your camera and just keep this thing on. It may be better.
Am I audible?
Yes, ma'am.
Yeah. See,
Yes, ma'am,
reproductive
you are.
aspects of PCOS, if you talk, most important thing is, PCOS has become a common ABC for every woman in all over India. Of course, the incidence has increased, but the wrong diagnosis. Patient comes with her daughter, 11 years old, menses irregular, or maybe there's amenorrhea followed by menorrhagia, and she will ask whether she has PCOS or not. Now, we all know that you have to label the patient only after 8 years of menarche and not before that. So that itself causes mental distress to the patient, and from there, that suffer starts. Her reproductive, what to say is aspects start. So, because of irregular hyperinsulinism and hyperandrogenism, of course, there is attached hypothyroidism, hyperprolactinemia, which is lot like, I always tell the patient they play like ringa ringa roses around the patient. So, definitely, you have an ovulation, and even if there's ovulation, there is poor equality, and therefore, this is very much distressing because many a times she gets pregnant, but she comes with a missed abortion or a non-viable gestation. So definitely the mental health starts, I would say that it starts from the age of 9 and 10 when the mother walks in and says, ki bhai PCO to nahi hai. The patient comes herself and says, no, mere ko to PCO hi hai, madam.
Are there do you think that the fact that not having regular periods which is something which is not normal or not looking like other girls or looking more masculine, do you think those aspects also contribute to distress?
Yeah, because of the obesity, because of the secondary, like, they have upper lip, they have their sideburns a little bit low, they have hair on the chin. So their body image is already, lowered. And with that, once they get married, definitely, they will say, despite having proper sexual activity for 1 year, ma'am, I'm not conceiving. So infertility definitely stands. Along with that, the poor body image because of her weight, which the society wants, zero figure. And most important is her irregular menses. She'll have amenorrhea followed by heavy menses. So, in India, wherever she goes for, suppose she has to go for some holy places, and then she has to come and take tablets. So definitely her mental health is definitely affected by this because infertility is going to follow.
Right. May follow, yeah. Got it, ma'am. Thank you so much. And I'll just quickly pass on the next question to Dr. Anis. So, Dr. Anis, about some of the metabolic aspects of PCOS, the fear of diabetes. You read in the social media about metabolic conditions associated with PCOS, the risk of cardiovascular disease. So, can you tell us a little bit about how you think that the metabolic aspects of PCOS are going to impact mental health?
Thank you, ma'am, for that question. This is a very important aspect while we are dealing women with polycystic ovarian syndrome. The metabolic aspect, the main culprit of polycystic ovarian syndrome is insulin resistance, and as we know that around 70% of the women with PCOS, regardless of their BMI, are known to have insulin resistance, which put them at a very high risk of developing diabetes at a very younger age itself. So the some women, when they come to us, are already diagnosed with diabetes, or some maybe at a level of pre-diabetes, which is of major concern to them, being labeled as diabetes or pre-diabetes at a very young age itself, or thinking about their long-term complications, frequent monitoring, which all these aspects can cause additional stress in addition to the other aspects we discussed, like the fear of infertility, body imaging. In addition to that, these metabolic consequences can also lead to increased stress among women with polycystic ovarian syndrome. Other than diabetes, they are also at increased risk of cardiovascular diseases, like they can have associated hypertension, atherogenic dyslipidemia, endothelial dysfunction. So being labeled as high risk of cardiovascular disease also can cause additional stress and anxiety among these patients. And other thing is their obesity is a biological driven condition where they have insulin resistance is the main mediator. So regardless of following lifestyle measures, they may not lose weight. That also can cause additional stress among women with PCOS. Then coming to the hyperandrogenic features, the 60 to 70% of the women has hirsutism. So hirsutism is not like in PCOS needs lifelong treatment. They may need repeated lasers, repeated waxing. So that the loss of femininity and the appearance and the stigma, so social stigma associated with it, can add extra stress and anxiety among patients who has got polycystic ovarian syndrome. In addition to the hirsutism, they can have acne, they can have androgenic alopecia, they can have acanthosis nigricans. All these can cause additional stress, which can later translate into anxiety or depressive disorders.
And maybe a little bit, Dr. Anis, would you like to talk about what the impact it has on their marriage prospects and the stigma and discrimination, around that, if somebody already has pre-diabetes or hypertension or dyslipidemia prior to getting married?
So this is also a common scenario which we come across while we are in OPD. So the moment they are diagnosed with polycystic ovarian syndrome, like ma'am mentioned, their major concern is about fertility and whether they will have children. Sometimes people, they consider that polycystic ovarian syndrome means they will not have children and it is infertility, and they are also worried about the complications and miscarriage which can occur, like if they are pre-diabetic or diabetic, whether they are at increased risk of developing these complications. So these diabetes, the fact that they may have diabetes or pre-diabetes, when you look at the aspects of fertility, they are maybe the level of, that is one factor which causes increased level of stress among them.
Thank you so much, Dr. Anis. And quickly, so the next question. So probably what everybody on the forum is thinking, that as doctors, we already have so many things we need to tell the patient during the consultation, right? We have to tell them the right diet. We have to tell them the right exercise. We need to explain the diagnosis. We need to do the investigation. So there's so much that we already need to talk about. And is there really time in the clinic to talk about mental health? So Dr. Shweta, what I would like to know from you is, are there any quick ways in which we can assess emotional well-being or mental health in young women with PCOS? as you all know, we all work in, and you know, Dr. Shweta, because you visited hospitals as part of your research, you know how rushed everything is, and there are resource constraints, time constraints. So in this setting, if you had a few tips and tricks in which we could, talk about mental health in young women with PCOS in the kind of settings that we have.
Yeah, that's an interesting question. And as a psychologist and as a researcher, I do look at this aspect. Like, I get it when the doctors are so busy. How do they address mental health issue along with the biological questions that they have? One thing that has worked a lot in cancer research is what we call as distress thermometer. It's easily available online. You can look up the research as well, and it's an interesting thermometer. It's like a thermometer that is given 0 to 10, and the patient will have to just note down what do they feel at that moment, how much distress do they feel, and there are some problem areas mentioned, talking about social aspects, talking about their personal issues, maybe lifestyle related issues. So that can be noted down, and this can happen even before the consultation takes place. So in the reception area, when the patient is waiting, maybe these could be handed over and quickly carried out by the patient too, and then taken inside and spoke to the doctor about it. So that's one way of looking at it, I feel would be beneficial. One other aspect that as doctors, if you have enough time to have conversation on, is to recognize or ask very basic, how are these symptoms impacting your mental health? Just ask that question. Sometimes being direct and being direct about the topic is very much important than going round and round and trying to address the issue. One thing that we can also talk about, which especially in an Indian setting where there's a lot of pressure on the doctor and they have a lot of patients that they're looking in, is to ensure that they have certain resources available and they can refer them to a psychologist. I would suggest preferably a psychologist to begin with, so that they can address a lot of questions that may be more neurotic, more situational, more related to their condition. To give you an example, talking about PCOS, we discussed about lifestyle changes, and almost all the doctors here mentioned that they have to control their diet, they have to maintain a diet. But what about people who have difficulty to control their impulses? And we have patients who find it difficult to control the impulses. And I'm sure you might have experienced this too as doctors, that when you're emotional, when you're high on emotions, you tend to eat a lot. And that happens a lot among PCOS women. So, can we have certain resources where they can refer to a psychologist, talk to a psychologist about it, and get the necessary consultation they needed? Yes.
Thank you, Dr. Shweta. So I love that part where you said just a simple question. How is this impacting you? How are you coping with this? So if you don't have time for a long, questionnaire and such complex things, even just asking those two questions. And many women are not distressed. So that winds up the consultation and say, doctor, I'm doing okay. And then maybe out of 10, one or two of them may be the ones who have some kind of significant distress. And then we could just simply, focus on those women.
Yes. Yes.
So my next question is to Dr. Bharti More, and this is a loaded question. And please, I would like to tell the audience that I have researched and and I've collaborated in research where people who I have treated with PCOS have been interviewed. And I would like to know from you, Dr. Bharti, do you think that we as healthcare professionals contribute to distress or anxiety for women with PCOS? And how do you think, how could we speak maybe a little bit differently, or what different words we could use, which would probably, improve the way we communicate with women with PCOS?
Yeah, Tejal, as I told you, this PCOS girls, they are brought by their mothers, basically they come saying that, and you can see it, you can see the mother is nicely fit and the girl is, overweight and sort of not very active in the conversation also when they enter the OPD. It is the mother talking and she doesn't talk at all. So first of all, I make them sit. I see to it that there is nobody else besides the mother and the patient. My staff, everybody's out. It is only the three of us. And then, you be very compassionate, very kind with them, listen. And I always will tell the patient to talk. I will tell the mother, you just wait, madam, let the patient talk. And sort of I make her speak out, whatever is a chief complaint. And if time comes, I sometimes tell the mother, आप थोड़ा बाहर रुकिए मैडम, मुझे जरा पेशेंट से अकेले में बात करने दो. So like, when you talk to them alone, then they open up better. Because, because of the overweight, as it is, they have had a poor body image and, social stigma. Like, whenever she opens up and tells me, whenever I enter my class, even the 8th standard and 9th standard ones, whenever I enter my class, Arey, jadi ali, sort of the whole class keeps on seeing. So she opens up. So the body image, you have to be very kind and compassionate, and you have to tell them that if you follow a proper diet, a proper lifestyle, see, many of them don't go in sunlight for half an hour. They don't have time because school subah ka hai. So then, when vitamin D supplements help a lot. And most important thing is change of lifestyle with diet, exercises. If you really give some 10-12 minutes detailed consultation with what exercises, what diet, even in sunlight, even if they can't go the weekdays, they can go on a Sunday, after a heavy brunch. So that helps them a lot. And you have to be very kind and polite with them. Try and talk directly with them, and as much as history you can get out, and you have to be directly in contact with them and convince them completely that change of lifestyle, diet, because they are more of raste ka kachra every time, twice a week, thrice a week when they go for classes. And nowadays 11 12 is such a packed schedule. They come from school, they'll have just little food and then go for classes, and they're there till 9 o'clock in the night. So though no dabba is taken, and they come out on the road and they have that dosa and all that junk food. So unless that is stopped, you have to tell them, you take home cooked food, you take your dabba, have a roti bhaji. Roti bhaji also, there's a sort of, when
What
friends
I'm
come together.
understanding, Dr. Bharti, from what you're saying is one is that you need to give time to the patient, like maybe a
Absolutely.
detailed consultation. And what I
Detailed
love what you
consultation.
said, that many
Yeah.
times in the consultation, the daughter is not given much of an opportunity to speak, and the
Stop.
mother is like, fix her, and you tell her what to do. So I think the time that
Absolutely.
you give the patient, the kind of communication, like a patient empathetic listening, and
Yeah.
guiding them more in detail, because these are young women, and giving
Yeah.
them time. I think that's the magic question. Of course, the million-dollar question is, how do we find the time? But yes,
You
I
have to give
understand.
time. You have to give time.
Thank you so much. And Dr.
Thank you.
Anis, the next question that I wanted to ask you, and this is a little bit maybe out of the box. So we are using a lot of GLP-1 analogs, GIP-1, dual GLP-GIP agonists now for the management of obesity, and many young women with PCOS are taking these medications. We also know that women with PCOS already have mental health issues many times because of the condition, and some of these drugs are known to exacerbate mental health. So have you had any experience in any of your patients who've used the medications and it has affected their mental health adversely? How do you feel about that? Do you check for mental health before you initiate these drugs?
Thank you, ma'am, for that question. Regardless of the pharmacotherapy or GLP-1 use, the women with PCOS are at increased risk of depression and anxiety. According to the guidelines, they advise screening at the beginning itself when you are before initiating patients on pharmacotherapy. It's better to have a baseline screening about their psychological status. We can use simple tools to assess, like Dr. Shweta mentioned. We can use simple tools to assess their depressive scores. And so coming to the depression, it is driven by, previously we have discussed hyperandrogenism, body image issues, and obesity, all that can attribute to their depression or anxiety. And coming to the GLP-1 analog, so before starting pharmacotherapy, so it's important to have a baseline screening. The second, when we come to the GLP-1 analogs, in the randomized control trials, there is which lacks evidence to support that use of GLP-1 analogs increase the risk of depression or suicidal ideation. But however, in post-marketing studies, there are some concern. But recently, FDA also has made a comment on this. It does not ban the use of GLP-1 analogs among patients with PCOS, but however, we should have a baseline assessment, and also we have to be vigilant when we use these drugs.
to offer them the benefit of the medication, but we also screen and we kind of make sure that at least what we're giving is not affecting them adversely. Thank you so much, Dr. Anis. And the last question is to Dr. Shweta. And so Dr. Shweta and Dr. Chitra and I, we worked on some some qualitative work which we've done on PCOS. And very briefly, we have the last 3 to 4 minutes. Dr. Shweta, would you like to summarize what is the study that you have done and what are the findings of that study?
Yeah, sure. I'll quickly talk about the study, although I won't go detail into it, but what will benefit to you all. One thing that we noticed, and I think we've been discussing about it, is the genderedness of PCOS itself, how much the mother's role is in the PCOS itself. So one thing that we noticed is the two kind of patterns that we see in PCOS. On one side, we have mothers who are highly supportive and constantly involved in the treatment process, and on the other hand, we will have like mothers who are supportive, but at the same time they are overprotective, anxious, and they're constantly fearing about the marriage, the infertility issues. Will my daughter have this? And thinking about the next session as well, like this generally happens with adolescent kids and their parents, like the conversation that happens. One thing I feel through the research that we notice is it's not just about educating the child, but also educating the parent. One thing is, because of the genderedness, mothers can act as a great facilitator for any kind of conversation. You want your child to be well, so you can ask the mother to maybe follow the lifestyle that is necessary. You can tell the mother what is needed. But at the same time, when I say parent, it also involves the father as well. And having more normalized conversation between the parents to be more involved in the child care, and also the PCOS itself will also help us to be more aware that it's not a gendered thing, but also about both parents being involved in the treatment process. Yes.
If you remember, we had this interesting experience when we did the study. So many women, when we called them up to be part of the study, they actually said they're too busy and they can't talk.
Sure, yeah.
So we had one of that experience also. So
Yes.
many of the women were like, this is something that you don't want to talk to anybody about, and this
For
is a
sure,
deeply personal thing, and things like that. So yes, parents can be of both types. And what I take away from there for my practice is that when I'm sitting in the clinic, I just observe the parents and I try to figure out what kind of parent this is, and then we tailor the consultation to that. And it is true that till today, and all the gynecologists and doctors will agree, the main question the parents always have is, will there be a problem in marriage, and will my child have good fertility? So so we are all works in progress, and hopefully we will see a new future for women with PCOS. So I'm deeply grateful to all the panelists, and in very brief, I'm going to summarize what we talked about. And what Dr. Shweta talked about is that we share a lot of knowledge and information during the consultation, but we come from the place where we're already familiar with the medical jargon. Often the patient may not be familiar with, but what Dr. Bharti also highlighted is that many of them come in with knowing the jargon, but not being really sure whether they have PCOS or not. So it is up to us as doctors in the interaction to try to figure out, one, whether they really have PCOS or not. And if they do, then we share information in a way that is not stigmatizing. Dr. Shweta highlighted how we can ask simple questions about how the symptoms are impacting the person. Dr. Bharti and Dr. Anis both highlighted the reproductive as well as the metabolic aspects of PCOS, and how all of them have a huge impact on the mental health of the person. The main reason I wanted to have this panel is because all the gynecologists and endocrinologists kept talking about lifestyle modifications. But what we have to understand is that if somebody is suffering from poor mental health, no matter what lifestyle advice you're going to give that person, it is extremely difficult for this person to execute that advice. And therefore, reaching out and getting resources like a psychologist, where they can sit down with the patient, help them figure out where they are, how they feel about themselves, and once the mental health is better, they will actually be able to execute what is it that you want them to execute. With that, I will close, and I'm handing over the session to Dr. Uday Thanawala for the next panel discussion. Thank you, Dr. Shweta. Thank you, Dr. Anis, and thank you, Dr. Bharti.
Thank you, Dr. Tejal. Thank you.
Thank you, ma'am.
Thank you.
Can you hear me now? Hello?
Yeah, we
Okay,
can
so
hear you there.
yeah, thank you so much, and welcome to this uh, wonderful webinar, which has been arranged by the uh, Endocrine Society and NMOGS. And after this wonderful discussion on all the metabolic health and the mental health, let me just go ahead and uh, let's talk about adolescent health. So I have two of my three panelists in this session, and we have Dr. Suchita Kinjevarkar, who is the past president of the NMOGS Society. Plus, she's a great clinician with a huge practice in Nerol, and she is also a great teacher because we have this course running through Foxy where we teach our nursing staff and we empower them with all the knowledge to bring down the maternal mortality, a thing called as Manyata, which she is in charge of, and they're disseminating great knowledge, and she's been doing it for many, many years. Thank you, Suchita, for this, and welcome to this particular panel. And we have Dr. Jyoti Bobe, also the past president of Navi Mumbai Society. And Jyoti is a practitioner in Airoli and a great friend, and been has been as a huge clinical practice. Dr. Khushbu Agarwal is the other panelist who's MD Medicine and endocrinologist from the Department of Endocrinology, CMC Vellore. She has got a lot of awards, like the Best Researcher Award to her credit, and the winner of the ISBMR grant in 2022. She's got multiple national and international publications. So, with that short introduction of my three panelists, and I would really love to have even our previous panelists like Shweta to join in whenever she wants. And of course, Tejal is always welcome to butt in when she wants. So basically, we go back to PCOS, and this is all what about PCOS is all about. It has got many phenotypes. So when Dr. First panel discussed that we have a phenotype with normal ovaries but not too many symptoms, so we can have the D phenotypes, A, B, C, D phenotypes. But why are we today focusing on adolescent? Now, because the PCOS onset is often in adolescent and the symptoms overlap with normal puberty, as was just discussed. So it's a diagnostic dilemma, and early recognition prevents long-term reproductive, metabolic, and psychological issues. So this is exactly what we have been talking about. So let's come to some clinical cases. So when we have a 15-year-old girl who's got menarche at 12 years, cycles every 2 to 3 months, she's got moderate acne, a BMI of 28, and ultrasound report has shown PCOS morphology. Mother is also very anxious. She says, "Oh, I had PCOS. Does my daughter even has PCOS?" So, Suchita, how would you describe menstrual cycle? What is irregular menstruation in these adolescent girls? Because so many girls who, when after their menarche, they have irregular cycles. So, what would you pick up as an irregular menstrual cycle?
Yeah, so after menarche, we usually anticipate and accept irregular cycle irregularities. It can be amenorrhea for a few months, and then gradually she'll start getting quite regular cycles. But no ovulation, or I mean, after menarche, few cycles as it is can be anovulatory cycle. So I won't be in a rush to diagnose or label a person as PCOD, especially at the age of 15. So 7 8 years we should expect menstrual. I mean that much time for her cycles to get regularized. So at the age of 15, I will not like to label this particular patient as or the
So
girl
she,
as PCOD.
so she had a menarche at 12, so 12, 13, 14, 15. So
14,
she's
15,
3 years.
still, yeah.
Is 3 years. So anything what is defined according to literature is in the first post-menarche year, approximately 75% of menstruating adolescent report the cycles to last between 21 to 45 days. So first year we really don't bother, but more than 1 year to less than 3 years post-menarche, if the cycles are less than 21 or if they are more than 45 days, yes, we label them as irregular cycles. And more than 3 years post menarche, which what this possibly this girl will fall into, less than 28 or more than 35 days or less than 8 cycles per year if she has, yes, we will call it a irregular menstrual cycle. And of course, if it is more than 1 year post menarche or she doesn't get more than cycles for more than 90 days, it is going to be irregular cycle. So it is here's the importance of maintaining a menstrual diary by these girls rather than just coming and saying that okay, the cycles are irregular. What about the ultrasound diagnosis? Jyoti, what do you have to say about the ultrasound diagnosis in a girl of 15 years old with PCOS morphology?
Usually such girls come.
You are muted again. Please unmute yourself and maybe start your camera so we can see you.
Actually, usually these girls come with the sonography report of PCOS, but sonography diagnosis should not be taken into consideration because it is not PCOS when she comes so early. Usually, we advise fasting insulin for the diagnosis
Do
rather
you
than
do you
sonography.
do you do you advise fasting insulin? Who would? Suchita, would you advise fasting insulin, or Tejal, would you advise, or
Yeah,
I
yeah.
can ask, Komal, would you advise fasting insulin for diagnosis of PCOS in a young adolescent girl?
The young adolescent, it's really confusing whether we can label her as PCOS or not. Even ultrasound, we should not be labeling as PCOS because multicystic ovaries, and I mean, at that time, the picture is it's not very clear. Usually, it's the transabdominal ultrasound with a
Correct.
28
Correct.
BMI, fat abdomen, ovaries are seen, and multicystic nature. I really don't trust those sonography reports. Usually, patients come and say that this is PCOD and it's written as PCOD. But
These are
in your
anovulatory
case,
ovaries, anovulatory bulky ovaries.
Okay,
correct.
listen,
So
before we go to ultrasound we all agree. Ultrasound is a polycystic ovaries are observed in 40%, 35%, or 33%, 2, 3, or 4 years after menarche. So it is not may not be associated with any abnormality. So PCOS, like she very rightly said, you can't say that you can't use it as a diagnostic feature in adolescent, and especially until 8 years post menarche it may not have any meaning. But I'm coming back to Khushbu, and I want to ask Khushbu, what would you comment
yes,
on?
Uday, but when
Wait,
such
1 minute,
patient comes,
Suchita, 1 minute, 1 minute. What would you comment on fasting insulin for diagnosing in adolescent? Would you do a fasting insulin in diagnosing in adolescent, Khushbu?
No, sir. Hi, good evening, sir. So, thank you for the question. I agree that the diagnosis of polycystic ovarian disease is difficult in adolescents because of two reasons. Not just because the ultrasound is useless practically in the first 8 years, but also because these girls are very, very impressionable. We have to remember we are Indians, and by nature we are a little hirsute. So, what may qualify the because everybody has an impression on as a what a girl should look like. They come with a lot of distress. At least they come to us and they say that we have these sideburns, we have this upper lip, and
Khushbu,
maybe they
will
have
you
some
do
irregular.
fasting insulin in this
No, sir.
girl? Tell me that.
No, sir.
Fasting insulin, will you do or no? Okay, so that's what we don't do too many investigations in these young girls. So I don't think we really would agree with what
but
Jyoti is
Uday,
saying.
if not fasting insulin with this BMI of 28, I would definitely do at least
OGTT.
fasting sugar,
They would do an OGTT.
HbA1c,
We would
and
do an
then
OGTT.
OGTT. Correct.
We would definitely do an OGTT, but I don't think insulin is being done. So basically, in adolescent, both hyperandrogenism and ovulatory dysfunction are required to be called as PCOS. Ultrasound and AMH is not recommended due to the poor specificity. So basically, a physician role is to distinguish normal puberty with PCOS, and of course, adolescent friendly communication, as Bharti has said, and handle parental anxiety in this case, because yes, many people say that there is a phenotype which could be passed on, and it could be in the next generation also. So basically, pathogenesis of PCOS as it affects adolescent is often discussed in terms of a two-hit theory. This refers to a stepwise process in which the first hit is an inborn congenitally programmed predisposition, while the second hit arises from a proactive factor such as insulin resistance. And in investigations, AMH should not be done. Glycemic status should be done like OGTT, like what Suchita has said. and insulin resistance is a pathognomic factor in PCOS. However, clinically available insulin assays are of limited clinical relevance and are not recommended in routine care. So that is where we come to the guidelines, what is being said in the guidelines. But at the same time, any comment about women at risk? You may not have these diagnostic criteria. Jyoti, what is your comment on diagnosing women at risk at this particular young stage when you don't have a very clear-cut diagnosis of PCOS?
Actually, this girl has BMI of 28. Her mother had PCOS. Most probably, she must be having family history of either diabetes or hypertension or
Yes.
obesity. So
Yes.
definitely, this girl is at risk. So proper counseling is very much essential for this patient.
Yeah, so probably you'll tell her that you better get on track, don't
Yeah.
put on weight, get exercise
And
done, and
basically,
follow up this woman,
yes,
this girl requires a proper follow up. So you label as at risk, so that to start your basic treatment of lifestyle change and all, you have a at risk category in these young girls who you feel may ultimately develop a PCOS pathology, full blown PCOS. Anything?
actually, I will start with simple things like I will have little empathetic attitude. Secondly, I will guide her about diet and tell her to do whatever activity she likes. Because suppose if I tell her to go on walking, maybe she may not like. But if this girl likes dancing, I will
Exactly.
recommend her to that type of activity. Plus, I will tell her mother how to do diet and all that, means how to track her diet and what things she can cook for her.
Yeah, so
And
that is
maybe
about
I
the
can tell the
lifestyle
girl
change.
also.
So we have the 17-year-old who has cycles every 50 to 60 days since menarche.
Okay.
She is hirsute because the FG score is 10 and she's got acne and BMI is 30 with a normal hemoglobin. She feels depressed, withdrawn and avoids social events. Now, when is hirsutism pathological? Suchita, when would you call, or let me ask this to our endocrinologist. Khushbu, when would you call hirsutism pathological? And
So,
what investigations will you do when you get a young girl who is hirsute?
thank you, sir. It's a very interesting question and a very, very important question, especially in the adolescent setting because they are very, very sensitive to the hirsutism part. There is not a specific cutoff for Indians defined, but different studies have taken FG score, modified FG score of more than 6 or 8 as important for Indians. Now, here's the problem: it doesn't consider the areas that are important for a girl like sideburns. It doesn't there are certain androgen specific areas that are not considered, like the perianal area that is there. So when would hirsutism be pathological? The guidelines mention if it is a problematic, if it's a problem to the patient, we have to address it either by local methods or by hormonal methods. We have to address it. Second, I would consider if it has, if it is associated with features of virilization. Would that be if there is deepening of voice, if there's a muscular body type, if she has clitoromegaly, if she has balding, if she has severe cystic acne, especially on the lower part of the face, if she has acne that is specifically premenstrual, or if it is stays throughout the face, if she has other features of insulin resistance, that would tell me that this is probably pointing towards polycystic ovarian syndrome or any other hyperandrogenic uh, disease. So I would like to evaluate on that direction. So then coming to the biochemical evaluation in such patients, baseline metabolic workup, as previous panelists have already mentioned, fasting blood glucose, postprandial blood glucose, fasting lipid profile. Most common endocrine cause hypothyroidism, TSH has to be done. Then we have to do prolactin and dilution. If a patient has features of Cushing syndrome, then 8 a.m. cortisol has to be done. I am from my practice is in Tamil Nadu. Over here, there is a lot of lean PCOS. So we have a lot of non-classical congenital adrenal hyperplasia. 17-hydroxyprogesterone kind of becomes important over here. And I'm not sure how important is it in
DHEAS says you have to do DHEAS
yes,
over there,
DHEAS and
17-hydroxyprogesterone.
androstenedione. Yes, that also has to be done. Uh, I
So
think
total
that's
and
about it.
free
And then if you
testosterone
have clinical
for
features,
for for hirsutism, you would do a total and free testosterone.
um, so testosterone in my practice, like it does not have a very good sensitivity to the features, sir. But by and large, if the values are more than 140 nanogram per ml, then I like it's more to rule out the other causes rather than to I'm not sure what levels you guys see, but
Can I speak, Uday, in
Yeah,
between?
sure,
Because
sure.
we see patients when they come to us as a primarily menstrual irregularity, abnormality, and then they are obese, BMI high and all. So for such patient, probably I may be doing serum testosterone
No, no,
to
no.
see
No,
whether
Suchita,
she is
you're not getting.
hyperandrogenic, whether
No.
she has hirsutism or no hirsutism. She is obese, she has irregular
So
cycles.
you will do a testosterone in that patient?
Yes, I will do her testosterone in this particular patient along with HbA1c
No, you
fasting
said
sugar
you said
and
patients
serum
who are not
testosterone.
hirsute. Patients who are not hirsute, will you do testosterone in the
Yes,
patient?
still probably I will do it because to know
Do you
what
agree,
is her
Khushbu?
status
If a patient is not hirsute, will you do testosterone?
at the age of 15. Your previous patient, I may be doing. If I'm doing
This
metabolic
yes.
one is
workup,
17.
I'll
This
be
one is
doing
17.
testosterone.
This one is 17. Yeah, Khushbu?
Sir, maybe as a stage, maybe not right away, but if I can't find the other causes and if my patient is still having menstrual irregularity, if my initial blood tests are negative, yes, I would like to do testosterone just to rule it out rather than so that I'm not missing anything. It's very
So if
unlikely.
the patient is not hirsute, Suchita, what I think is you have to make sure that she has not done any laser treatments, etc. Otherwise, you do the testosterone. Otherwise,
See, apparently she is not hirsute, but I can ask them, are you concerned about all these things? And
okay,
I mean, have you noted such thing? But still,
okay.
only serum
So
testosterone, I don't think it's a big, costly investigation. So,
yeah,
along with
okay,
these two for sugar
fair
and
enough.
metabolism, testosterone to see whether she is hyperandrogenic or not.
Fair enough. So basically, I think Khushbu and Suchita have really very nicely said whatever the workup should be. Now, what about the treatment? Suchita, please go ahead and tell me how will you treat this girl?
Uh, See, if she is having hyperandrogenism, I mean, I usually
Irregular
do
cycles, hyperandrogenism, hirsutism, how
I
will you?
usually do testosterone levels
No,
in
no,
this
do अभी
patient,
अभी
and
ट्रीटमेंट पे आ जाओ अभी हो गया
तो
testosterone
अगर वो
अभी मैं
ज्यादा
treatment
है तो then I'll be advising her COCs, OC pills, which has anti-androgenic
so
kind of progesterone.
if her androgens are normal you will not be advising OC pills what about Jyoti tell me
If she is not hyperandrogenic and her main problem is cycle irregularity, I may advise her only periodic withdrawal bleeding and not COCs. But if her testosterone is on the higher side, to this patient, I'll advise maybe 6 months, 8 months of OC pills.
Jyoti your comments
Actually, I prefer cyclical progesterone for such patient. If there is, even if there is hirsutism, I give either aldosterone with progesterone because I am
okay now
not
let me
very
tell you
keen about
okay
COC.
since we are going a little short of time let me
Yeah.
tell you OC pills is the treatment of choice for these patients because and of course progesterone and
Usually
anti
they come up with a
definitely
headache,
are
severe headache, and they forget to take tablet. That's
let
the
me please,
problem.
yeah, please let me just see what the
Yeah.
literature has said. Despite the low incidence of general side effects, the use of progesterone-only contraception is not ideal in this group patients. And only progesterone withdrawal may not be good because they do not exhibit the same increase in SHBG and subsequent decrease in free androgen index. So it is important to use OC pills in most of these patients because they are hirsute. And even if they are not hirsute, the cycle regularity which is achieved with OC pills is much better. So in technically speaking, I would like to have Komal give her inputs also about treatment.
We start COC,
Khushbu,
mother is very
sorry,
anxious.
Khushbu. Yeah.
Hello. Yeah, the moment we start OCPs, mothers are very anxious. And secondly, if acne is a
Jyoti,
problem,
let's talk what we are supposed to do. Khushbu, I want your inputs on starting OC pills for young girls.
Patient's acceptance for
17-year-old.
OC pills is not that high, Uday, at the age of 17. Whether you label it as OC pills or whether you just label it as hormonal pills, they are not comfortable. They are not,
I'm
very
asking you
regular
what,
in having
no,
very
no, I
regularly OC
agree.
pills.
Let's keep that as a second thing, how you counsel a patient to take it. My aim is that what is the correct treatment for these girls? What do the endocrinologists
If
say? Tejal,
androgen
what do you
excess,
say?
How we start the treatment is we give combined oral contraceptive pills for 3 months, and then we advise lifestyle modifications. If the patient's BMI is a little high, we may also advise metformin at the same time to these patients. And after 3 months, we assess whether the patient can come off the medications. If because not only for the regular cycles, but for the other symptoms, oral contraceptive pills work very well, even for the hirsutism, even for the
Yeah.
acne. So
So my understanding is for acne and for this thing, at least 7 or 8 months of treatment is required.
they do well. The hirsutism part starts to come down a little because we also ask them to go to dermatologists at the same time. The
Yeah.
new
So
hairs.
new hairs will not grow, but the effect comes after 7 or 8 months.
Yeah,
So we
yeah.
tell the patient to continue this OC pills for 7 or 8 months for the skin effects to come up.
Yeah.
Cycle regulation is much better. Technically, we should be always advising a OC combined OC pills to these girls, but if they are not willing to take it, like Suchita says, and you are very right with that, and Jyoti says that the moment they hear OC pills, the mothers and all put their things up and they would anyway stop it. So for cycle regulation, yes, it is acceptable to have a progesterone withdrawal every month. Now, what about metformin? Suchita, your take on metformin?
The patient, if this girl has a high BMI, and definitely her metformin is going to help her, so I will not hesitate to start metformin in such.
Excellent, excellent. Jyoti, what about you?
Yeah, I give metformin very regularly.
Okay, so this is a slide about what to use. Combined oral contraceptive treatment are the first line pharmacotherapy for management of menstrual irregularity and acne, and metformin is superior to OC pills for weight reduction and improved dysglycemia. And they have similar effects on hirsutism, but they may be needed to pair with other modalities of reducing hair growth. And significant metabolic and psychological comorbidity does exist. So we will quickly go through this life. Now, this is something which you have to be very careful today in telling the patient to get on the weighing scale and that you're overweight and all, because I've had some patients who written back that, oh, he's body shaming, etc., etc. So you have to be very careful when you're dealing with adolescent with this, and you have to tell them to avoid junk food. And what we normally advise is a plate method, like what Bharti was trying to say about dal sabzi and all that. And of course, exercise recommendation very well put by Jyoti. Let her pick up an activity what she likes. Otherwise, she's not just going to follow it. So that is important about lifestyle. Mental health, we have had a very big discussion on this. So I'm not going to
So,
again say
Uday,
much.
can we know from our endocrinologist colleagues here that what is the indication? I mean, when do they use flutamide and spironolactone?
So, ma'am, the recent guidelines actually have advised against the use of anti-androgens unless and until the symptoms are very, very severe. So, flutamide and bicalutamide should not be used at all. Spironolactone also, you have to be cognizant of the fact that they cause menstrual irregularities. That is one thing that you have to see. If that is the main concern for your patient, then spironolactone will not help at all, anyways. And that is why the treatment comes back to combined oral contraceptive pills with local treatment for the hirsutism as and when needed. But if the hirsutism is very bad, or if you're thinking of hyperandrogenism because of other causes like a tumor or something, in those cases you can give spironolactone. But others are now not recommended because they cause liver damage. So they
And
should
which
not be used.
particular OC pill, like with cyproterone
Dosperenone.
acetate?
All of them are pretty much equal, ma'am. It's not about the content of progesterone. The progesterone doesn't even matter. It's the that they're increasing the SHBG that has the major effect. So we like to have the estrogen component smallest to have.
Estrogen increases SMBG, right?
Yeah, no, we want estrogen to be minimal so that there are no metabolic side effects. The like of OCPs that everybody is scared about. So we start with a combination of ethinyl estradiol 20 microgram with maybe levonorgestrel that is there. We have that in our pharmacy. If that doesn't work, then we will shift to diane 35 or maybe a combination with cyproterone acetate. If that doesn't work,
That is
then
not very popular now, no? Cyprodone acetate because of the side effects of the liver, etc. So
yeah,
dosperenone is safer.
yeah.
So I use the
But
20
that
milligram
also
with
has the equal
dosperenone.
side effect of making blood sticky. I mean, thrombophilic.
Actually,
So
headache is the
that patients
commonest
with
side effect.
migraine, correct?
Headache.
And as it is, obese patients are prone for thrombosis.
Yeah.
Yeah,
So
so
if
you have to keep the
lead to
estrogen part minimal. So that's why 20 microgram is like recommended. If it is not working on, then you have to go to 30 or 35 combinations. So that is when we go to those, ma'am. We start with 20, definitely.
Everybody starts with 20 generally. So anyway, now about mental health, a lot has been discussed. This is what I find very easy and simple to use, the WHO 5 questions. What Shweta was saying, some 20 things, I think it's similar to that, the thermometer, what Shweta was talking about. And it is basically, mental health is very important to screen in all girls, including all adolescent girls, because it is one of the ASHRAE recommendations that all girls of PCOS have to be screened for mental health. So, 15-year-old girl, normal BMI 22, last 5 minutes left, a lean PCOS basically, and we have talked about the lean PCOS already. Anything you want to add?
So this lean PCOS at the age of 15, if she is lean and normal BMI just for her irregular cycles, do we need to treat her? I mean, investigate her.
Can I just say
Label
two
her as
things?
PCOS now. At the age of 15, irregular cycles. I may just give her periodic progesterone withdrawal.
Yes, agreed. But we need to keep a watch, and I want inputs like, let's
So
say,
lean,
17-year-old.
lean amenorrheic 15 years, should I do OGTT and HbA1c and all those stuff?
No, no,
No,
no. We will do OGTT. Definitely, you do
Why?
OGTT.
Why? Just with
Yes.
amenorrhea, just with irregular cycles?
No, no.
ma'am, I have something to add to this discussion. BMI is not a very good indicator of obesity in our population. Just because the BMI is normal doesn't mean that she is not obese. If you have other features suggestive of PCOS, very simple measure would be to take the waist circumference. If it is suggestive of, if it is more than 80 centimeter in a female, you know that you're dealing with a girl who is having who is pointing towards a normal PCOS rather than a secondary cause of PCOS. And then of course we have other features, like if you're having breast atrophy, if you're having irregular cycles, and if it is going in that direction, you can start evaluating in that. But there are studies that have shown that lean PCOS, even 40 to 70% actually is like obese PCOS only. It's just that the weight is less. We have higher fat percentage at lower BMI, so it's not like they are uh, normal per se. So they are normal weight obesity, and Indians are prone for this. But that being said, maybe if she is not 15, maybe if the age was 25, you would probably do a lot more comprehensive evaluation of the metabolic and the secondary causes of PCOS. But the treatment line would remain the same. They unfortunately,
Metformin, Khushbu, metformin in lean PCOS.
all the
What
treatment
age?
modalities work very less in lean PCOS. It's a very, very difficult part to treat. The lifestyle modifications, the metformin combined OCPs have very less, like compared to obese PCOS, they have lesser impact in all of these conditions
Yeah,
for some reason.
I was under the impression lean PCOS ko metformin, there's no point in giving metformin like
I
Suchita.
meant to the people who are obese, like by abdominal obesity. Like if I have like other causes of lean PCOS, then of course like non-classical CH बहुत common है sir. तो उनमें metformin का कोई काम नहीं है. If she's completely lean, like BMI of 18 and 19, and then she's having polycystic ovarian disease, then of course metformin will not have any role. But 20 to 23, अगर वो थोड़ी सी मतलब शॉर्ट फ्रेम में है तो उसका वेट वैसे भी ज्यादा नहीं होगा, तो उस टाइम अगर उसका BMI 22-23 है एंड शी इज हैविंग अ हाई वेस्ट सर्कमफ्रेंस, इट्स प्रोबेबली pointing towards normal weight obesity with PCOS rather than this. So she probably has high fat percentage. Metformin may have a role. Again, very questionable. Very
Very
questionable.
question. So that is what I was even thinking, but literature says that metformin treatment was associated with improvement of disordered menstrual cycle even in underweight patients with PCOS. So I had that mental block of not giving it to lean PCOS girls metformin, but the literature says otherwise, that you can give metformin in that regular dose even to lean PCOS to get a better result. So that is about lean PCOS, and I think this is the algorithm for lean PCOS, what we have got. And I think with that we can end. Tejal, are you there? I think everybody is gone except us, three of us.
Pam has written on the group that she has a meeting or something. She has to go.
Okay,
We are
so
there, very
basically
much
don't
there.
rush to diagnose PCOS in uh, young girls.
So,
Menstrual
Uday,
tracking is
you
very
mean at the
important.
age of 15, lean PCOS will start metformin?
No, I'm not talking about that particular case of 15.
Acha,
Don't get stuck in that case of 15.
I am
In lean
restricting
PC
discussions only
adolescent.
to our 15 and 17 age group.
No,
No, no.
but if there's a lean PCOS, one can start metformin. That's what it is. So basically, team approach. So we have a good team here, and thank you all very much for this excellent discussion. Thank you, Suchita. Thank you, Jyoti, and thank you, Khushbu. Khushbu, you give excellent
Thank
inputs.
you, Dr. Uday.
Santosh, you can
Thank
please
you,
take
sir.
over and wrap it up, please.
Everybody, thank you.
Thank you, sir.
So
I learned,
thanks,
Thank you,
Bindu.
Dr. Khushbu.
I learned a lot from all of you. Thank you so much.
Thank you very much.
So thanks a lot from the Endocrine Society of India, part of the PCOS Task Force. I think it was a great discussion, and we had lot of inputs coming in from all different specialities, and that's what makes medical specialty a great thing, is it not? So we should interact with each other more to understand more how we all practice and what differences we can make in our practices to improve the quality of patient's life. Finally, that's what matters. So thanks a lot. So thanks a lot to all of you.
So
One, and
I
all.
think Vishwas has just joined because he wanted to do the question answer session. So Vishwas,
No, I'm here since long, sir.
करो ना यार तुम यार अभी
Uh,
ज्वाइन किया है तो करो
and
सेक्रेटरी हो.
yeah, and I realized that we need a lot more discussion on these topics than we had today. But it was an excellent this program and excellent discussions, and a lot many points to ponder upon. Hmm. And
Actually,
from NOBGS, as the secretary of NOBGS, I would like to thank all our endocrinologist friends who have taken efforts to be here and to enlighten us with the endocrinological aspects of the PCOS. And I thank Dr. Santosh, Dr. Tejal Latia, Dr. Chitra Selvan, Dr. Svikruti Jaina, Dr. Khushbu Agarwal, Dr. Anit Joseph, and Dr. Shweta Chawak. I also thank all our past presidents, Dr. Uday Thanawala, Dr. Sujeta Kinzavdekar, Dr. Jyoti Bobe, Dr. Bharti More, and our present president, Dr. Bindu, and not last but not the least, all the participants. And I see there are no questions, so it must
Yeah,
have
I
been
have
very
one
comprehensive.
question.
Vishwas,
Dr.
one question I saw.
Uh,
Is there a
Okay.
male counterpart for PCOS? Somebody has asked male counterpart.
actually,
All the endocrinologists can answer that.
Jyoti has raised her hand. I don't know what she wants.
actually, I wanted to know at what age you can start semaglutide. What is the youngest person means where you can start semaglutide in morbidly obese patient
After puberty, it's
after
approved.
puberty?
It's approved in after 12 years of age, ma'am. But ideally, you should wait for the puberty to get over because we don't know the impact of these drugs on the growth.
Mhm.
So once the puberty is completed, if your patient is morbidly obese with having secondary complications beyond obesity, who is not responding to lifestyle modifications, these medications can be considered. Interestingly, there is a counterpart to PCOS, but even for them, the testosterone goes down. It is called MOSH. It is morbid obesity related secondary hypogonadism. So they lose weight, the testosterone goes back up on its own. So we have high androgen. When we gain weight, they lose androgen. I don't know.
So there is also a concept that in male pattern balding, actually. So male pattern balding is one of the indicators where the offspring might be at increased risk for PCOS. So that they many times they use it as the male counterpart of PCOS.
Thank you very much.
Okay,
Thank you,
thank you all the
everybody.
participants.
Thank you, and good night.
Thank
Good
you.
night.
Shweta,
Enjoy
I
your
wanted to ask
weekend.
you one thing about what do you feel about this WHO 5 index instead of that you said thermometer 10?
I think WHO5 index works as well. Thermometer, the reason I mentioned the distress thermometer is because it's quite easy to use in a Indian medical
Is what?
setting.
It's an actual thermometer or it's a
It's actually a drawing of a thermometer. You can just Google it and you'll be able to see that. And there are some problem areas mentioned. So what they have to do is they just have to mark the thermometer. So irrespective of what background they come from, it's easy for them to understand.
So we are doing from the PCOS Society of India, we are now starting a study about mental health in PCOS. And what we had thought is we should do that PHQ7
Yes,
or
yes.
PHQ9 for this.
Mhm.
And This is a good input about the thermometer. So if you could just,
Yeah,
I think I will look into that. And you are in
sure.
Bangalore. You are in.
I'm in IIT Bombay. I'm a faculty
Oh,
here in Bombay.
okay,
Yes.
great, good.
Yeah.
Oh,
Thank you so much.
yes. Thank you very
Thank
much.
you all.
Good night.
Thanks.
Thank
Good
you.
night.
Okay,
Bye.
good night, everyone.
Good night.
Good night.
Bye.
Thanks, Roshni. Thanks. Bye.